Boom. Welcome, everybody. Um, this week we are discussing the immune system again. I'm going to do a little review, go more in depth into the different type of allergic reactions. That's important. I mean, there's two different types of allergic reactions you really have to know about. The first one, of course, is hay fever and food allergies and stuff like that, which everybody deals with, which usually are not a problem. But then the other type of allergic reaction is anaphylactic. Anaphylactic reactions are life-threatening. After that, I'm going to talk about some vaccines. That is a subject that is near and dear to like everybody's heart these days. I wonder why. And that should pretty much do it. It shouldn't be a very long session today, but we'll get started here. Maybe if my computer works. Here we go. Remember this guy? I like this guy. Kind of cute, isn't he? I'm going to shrink my Zoom screen over here so it's not in my way. Okay. Allergic disorders. We all talked about when an antigen gets into the body and we launch an immune response against it with by attacking it with the neutrophils and the macrophages, and then the B cells come along and produce antibodies, and the T cells come along and stick them with a pin and they die. It's a wonderful thing. Sometimes, though, we'll have a reaction to something and the immune system goes crazy, but the antigen is not all that bad. You know, it's stuff like too much gluten in your bread or hay fever. We usually call those allergens. I'm sure you've heard that term thrown around a lot. Allergen. An allergen is an antigen. It's just a mild one. But what happens is the immune system goes crazy when it really doesn't have to. So allergic disorders are when your immune system just kind of overreacts, you know, gets really dramatic, pulls out their cell phone, starts tick-tocking everybody. So moving down, let's take a look at what different types of allergic reaction we can have. There's basically 4 different kinds. Food and drugs. Okay, food, we're familiar with that. Gluten allergies, nut allergies. I mean, we lately in recent years, when I was a kid, I don't remember any such thing as a gluten allergy, but we learn as we go along. And gluten and nut allergies are a real big thing now. It could also be seafood. In seafood, you kind of have to watch. You can have a mild reaction to seafood, or you can have a very severe reaction to seafood. Same is true of drugs. For example, morphine. Some people are allergic to opioids or allergic to morphine, and they'll tell you that. Let me point out, and this is just a sidebar you can put in your little memory bank there. There are certain drugs will have side effects. And then people can also have an allergic reaction to a drug. A side effect to a drug, for example, morphine, is it makes you sleepy, but it can make you very nauseated. It also can make you constipated. So when the person says, well, I have an allergy to morphine because it makes me sick to my stomach, that's not an allergy. That's a side effect to the drug, which is really important when you ask somebody, okay, are you allergic to any drugs? And they say, yeah, morphine. Ask them, well, what does it do to you? Well, it makes me nauseated. That's not an allergic reaction. That is a side effect. Allergic reaction is when they develop a rash or their throat swells closed. That is a legitimate allergic reaction. Other types of reactions are inhalants. Inhalants are, I put the line right over the top of the word, didn't I? Yeah, and this is where it's got house dust and mites and stuff, but this also includes like hay fever, allergy season, when all those beautiful dandelions in our front yard are blooming. There's also contact ingestants, such as latex allergies, which we hear a lot about today, and injectants. Now, this can be a reaction to an injectable drug, but the more common one that you've probably heard of or seen before is allergic to bees. If a bee stings you and puts the venom in you, then that is a reaction. Some people will have an anaphylactic reaction to that. And that's why they walk around with an EpiPen. These are some of the examples I was telling you about. Rhinitis, that's the hay fever. That means rhinitis means your nose is going crazy and all over the place. Dermatitis is when you get a rash. Now, you can get dermatitis from an ingestant. For example, you eat the wrong food and you break out in a rash. So you don't have to get it just from contact like a latex allergy. Food allergies, what I've pretty much found with food allergies is it upsets your bowels more than your stomach. For example, people who have a gluten disorder or an allergy to gluten, they don't digest well. So it can manifest as diarrhea, abdominal pain, stuff like that. Angioedema is when your face swells up. I don't know if any of you ever saw that movie with Martin Short, where he gets stung by a bee and he walks off the airplane. He looks like the Pillsbury Doughboy. That was angioedema. So something to remember, those guys there. 4 different kinds of allergens. Moving on. Yeah, this is very important here because you'll often hear people say, well, I've been eating shrimp for years and years and never had any problem with it. Well, first thing you do is you have to actually get the allergen in your body that first time. So you may not have a reaction, for example, the first time you get stung by a bee, but then your body produces that immune response and you got all those antibodies running around in your body saying, oh God, I hate bee stings. And so the second time you get exposed to the allergen, then you have the hyperactive response to it. So you may have gotten stung by a bee once and not had any trouble, but then you get stung a second time, and that is when everything goes crazy and you have a hyperreactive occurrence. Now, moving on. Are there any questions on any of that before I go into the types of allergies? Coffee. There's 4 types of allergic reactions, and they're numbered 1 through 4. This is one of the very few times modern science has done things in a logical manner. Anyway. Type 1, 2, and 3 are what we call rapid responses. Those are the ones that occur right away. Yes, this information will be on the midterm. This is week 5. Next week is week 6. The information I give you next week will not be on the midterm, but will be on the final. So yes, this is definitely going to be on your midterm. That's a good point. I think I should make a little announcement to that effect. Anyway, type 1 to type 3 are quick responses. That's when, for example, anaphylactic, you get the bee sting. And that is a very severe reaction right there. It happens right away. And remember, I told you mediated by immunoglobulins. Immunoglobulins are another name for antibodies. Don't worry about memorizing, oh, is that allergic reaction an IgM, an IgG, an IgE? I'm not going to ask you about that. Just be aware that that's what those are. They are just another name for an antibody, and they work differently. If you really want to research it and look at it, it's really interesting, how IgE, how it reacts in the body as compared to IgM. But you're not expected to know those. So you have the atopic, cytotopic, and the immune system response, type 1, 2, and 3. Just remember type 1, 2, and 3. They are quick responses, as opposed to type 4, which is a delayed response. Type 1, or let me go back here a second. Type 1 is your anaphylactic reaction. That's when you get the bee sting, and that the IgEs go crazy with that. There's a lot of histamines involved in IgE. Type 2 is usually when you have a transfusion reaction or with hemolytic anemia. And then type 3 is the kind that goes with lupus, rheumatoid arthritis, and glomerulonephritis. It destroys the little glomeruli in your kidneys. That's what glomerulonephritis is. These are all autoimmune diseases where your body attacks itself. And next week, we're going to be talking a lot about autoimmune diseases, so don't worry about this right now. And again, you don't have to remember, what type of reaction goes with what type. I'm not going to ask you that. I'm not going to say, okay, what type of allergic reaction pertains to lupus. I'm not going to do that. I just want you to remember type 1, 2, and 3 are quick reactions, and type 4 is a delayed response. Anaphylaxis, this is very important because when you get the bee sting and your throat swells shut, you are having an anaphylactic reaction. It is a type 1. And there I was talking about the IgEs have a lot to do with histamines. There's this huge release of histamines, and histamines can do several things. One of the things is they can cause vasodilation. Now, vasodilation means your blood vessels expand, and your blood vessels are a pipe. Blood is going through the pipe. You have blood pressure. Well, when that pipe gets bigger, what happens to the pressure in the pipe? It tanks. So massive violation can cause your blood pressure to drop into the toilet. If it drops too far and you lose consciousness, that is called shock, which we will talk more about at a later date. But if your blood pressure drops in the toilet, well, we're talking shock. The one that people are probably most familiar with, where you're going to have all that swelling of the face and lips. There again, remember Martin Short in the movie. Hypotension is from the vasodilation, but this one right here, bronchoconstriction or bronchoconstriction. The histamines will cut. You're not only getting swelling in the face, you're getting swelling in your hands, swelling in your arm, but your windpipe is swelling too. And if that windpipe swells shut, you can't breathe. And that's what makes an anaphylactic shock possibly fatal, is people who get stung by a bee that have a massive anaphylactic reaction, they're going to quit breathing. They're going to choke up. They're going to say, I can't breathe. They're going to grab the throat. And really the only way to fix that is with an epinephrine. Epinephrine counters the histamines and gets the swelling to go down again. So that's why if you're allergic to bee stings, you should carry an EpiPen. Any questions on that? That's very important because anaphylaxis, literally, it'll kill you. Now, I've had cases where I've ate some shrimp before and my throat feels a little scratchy. That could be an allergic response to the shrimp, but not one that is life-threatening. But still, if you get a rash or your throat feels scratchy after eating seafood, it's usually the iodine in seafood that you're reacting to. It's a good idea that you just don't eat shellfish because you never know when that reaction might just really go hog wild, unless you want to walk around with an EpiPen. Personally, I don't like shrimp that much. Delayed sensitivity, hypersensitivity response, type number 4. There again, I'm always losing my thingamajig. This is type 4. And this can happen over several hours or days. This takes a long time. This involves the T cells and cytokines. Cytokines are interesting. They're released by the T cells. They're a big messenger that runs around your body and goes, beep, beep, alert, alert. You know, like Lost in Space, alert, Will Robinson, whatever. But this can be, this is a hypersensitivity reaction, but it happens over a long period of time. Boop, might want to remember that. Boop, might want to remember that too. So question. The nurse is assessing the client. Which of the following is a symptom that the client may be having anaphylaxis? What is that one symptom that you would be looking for if they're having an anaphylactic reaction? You want to do this like Jeopardy? And I'll just go do, 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 do. No, I'm not going to do that.
Wheezing.
Answer. What's that?
Wheezing.
Wheezing. You got ding, 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 wheezing, because their throat is swelling shut. So yes, you definitely want to take that seriously. Find my cursor again. There he is. These first two, here's different ways that the body reacts. And there again, this will go back to those IgE, IgM, IgG immunoglobulins. They all kind of react with the body in a different way. I'm not really concerned that these first two that you're really familiar with those, but there they are for your own personal edification. Epinephrine is very important because that is what we give the patient having the anaphylactic shock. And what it does is it interferes with the release of the vasoactive chemicals. That chemical are histamines. It blocks the histamine. It's like an antihistamine. And since I'm talking about that, we're talking, oh no, I think it's further on another slide. Never mind. We're going to get to that in a moment. But when you think of histamines and you want to stop the histamines, what do you think you would use to stop the histamines? Anyone?
An antihistamine.
Take an antihistamine.
Antihistamine. Very good. I heard it out there. Yeah, and I'll talk about that in just a moment. So if you have a friend and you're out there and he eats, this happened to me in Mexico. I had this, they put the fish out and they bread it. It was like really good. There was something in the breading that I reacted to, and I ended up with this huge rash all up and down my back. But being a nurse, I carry all my drugs with me, and I'll tell you how I fix that in a minute. I'm going to let the suspense build. Corticosteroids. We're talking prednisone, solumedrol. Prednisone is the tablet. Solumedrol is the injectable. A very powerful anti-inflammatory. Quite often, if somebody comes in with a huge reaction and we got to get the swelling down, we might use epinephrine right away, but it's a fast-acting drug. We'll also want to get some solumedrol, which is a corticosteroid in them, for more of a long-term anti-inflammatory response. Unfortunately, corticosteroids are very, very good at what they do. This is also the steroid shot when people get it in their knee. Their knees are swelling and sore, so they get a steroid shot in their knee. That's a corticosteroid also. But these drugs also have a lot of bad side effects. So it's not the kind of thing you want to take on a long-term basis if you can help it. But in the short term, they're wonderful. They're beautiful. A lot of times with an asthma patient, they'll come in, we'll give them albuterol to kind of get their lungs, their windpipe to relax right away. And then we'll give them some solumedrol to keep the anti-inflammatory process going more long-term until the asthma attack passes and goes away. Maya, you have your hand up.
Yeah, when we administer epinephrine, do we also call ER?
at the same time, or how does it like?
I would ask the person, if you are if you're giving an epinephrine pin to somebody, it's most likely the one that they were carrying with them. And they will probably want to decide whether or not they want to go to the hospital. We all know that hospitals are very, very expensive. So I would let the person, if they don't get better, by all means, you want to call 911. But if they just feel like an attack is coming on, they got stung by a bee, they know it's going bad, they get their EpiPen, they give them a shot, and then you start feeling better. I would probably, as a healthcare professional, recommend they go to the hospital, but I would leave that call up to them. Another situation where I find that is people with epilepsy. People with epilepsy will have a seizure. Seizures scare the living daylights out of you. They really do. A full grand mal seizure will scare the daylights out of you. But this is something they're familiar with. It's something they've been putting up with probably their whole life. They may go through the seizure for 2 or 3 minutes and then they get better. And they say, no, I don't want to go to the hospital. I have these all the time. So in a case like that, then you may not necessarily want to call 911. Or if there's a family member with them. If somebody does go into a seizure though, and you don't know anything about it, by all means, call 911.
Thank you.
And does that answer your question?
Yes.
Okay. I'm going to put a little sidebar on this right now. People will be tempted at times to get themselves into a car and drive to the hospital. That's not a good idea, especially with heart attacks and those type of serious problems. When you call 911 and the ambulance is sent to your location, you have a mini hospital there. A lot can go wrong between the time you put them in the car and you arrive at the hospital. So when people say, when someone has a heart attack and you say, well, I'm going to call an ambulance, and they go, no, I'll drive them to the hospital. Tell them no. The paramedic arrives. If they have another heart attack, they've got the drugs, they've got the defibrillator, they can do that. If they put them in their car and drive them to the hospital, and halfway to the hospital, they have another heart attack, there ain't nothing they could do. Pull over to the side of the road and do CPR. So it's very important that people realize that when you call 911, they're going to get medical care and medical treatment immediately. Driving to the hospital is not a good alternative. Okay, that's my sidebar. I'll get off my soapbox now. Moving on. Any questions on epinephrine or corticosteroids? Probably study epinephrine. Well, you'll get to all that in pharmacology. And yeah, you'll hit on it in pharmacology. Moving on. This is just a couple things that can happen to you in a hyperactive allergic reaction. Conjunctivitis, that's when your eyes get all red and swollen, your sinuses start dripping and running, and you start sneezing. Laryngeal edema, your throat can swell up. That can be fairly dangerous as well. Not as dangerous as the bronchospasm. Dysrhythmias, that's kind of rare. Urticaria, that's the rash that goes all over your body. Hypotension, that's from the vasodilation. Now, if you're doing an ingestant like gluten allergy or something of that nature, then you get the gastrointestinal cramps and diarrhea. There again, it's not the stomach that you're having trouble with, it's actually your intestines. And angioedema, where you just swell. So there are a couple of the wonderful things that happen to you with an allergic response. And there again, it's just basically telling you what I just already told you. I don't know. No. Okay, as I was thinking, snake bite. Snake bite is not allergic reaction. Snake bite is venom toxicity. So that doesn't really fit into this lecture, really. If somebody's curious about snake venom, I lived in, most of my career, I was in Arizona. We got a lot of rattlesnake bites. So I can tell you all about that if anybody's curious. Moving on, these tests I already told you about in a previous lecture. The blood test, the scratch test, or elimination test. This is what we do at home. Okay, I ate that. It made me feel bad. Well, don't eat it again. Kind of like that old joke where the guy goes to the doctor and goes, "Doctor, it hurts when I do this." The doctor says, "Don't do this." Complications. Oh, chronic allergies. You can develop nasal polyps from that. So that's just one thing that might want to pay attention to. Medical management. This is where I get to tell you about my experience. As a nurse, our job basically is to recognize an allergic reaction when we see one. If you're in the hospital, if you're out with your family eating dinner or whatever, you now know exactly what to look for, and you know if it's an allergic reaction or if it's something else, and you can also tell if it's serious or if it's mild. Now, when I ate that bad fish, it was a good fish, actually. It's not the fish's fault that got me an allergic reaction. It's my fault, actually. But anyway, when I had that reaction, I basically just took some Sudafed and some Benadryl. Pseudoepinephrine and the Benadryl help suppress the histamines, and eventually the rash will go away. So if you're out with your friends or family and they eat something bad and they start to get that rash, Sudafed and Benadryl does the trick. There's one more treatment for allergies. It's not really a test, it's a treatment. And that is desensitization. Has anybody ever done that for their allergies? Nobody? Basically, now the medical community would kill me for saying this, but it's almost a homeopathic treatment. We give you a tiny, tiny amount of the allergen a couple times a week so that your body builds up a normal allergic response to it, so that it quits getting hyperactive. So that's basically all it is. It's pretty simple. Just give you a little bit of the allergen so that your body can react in a normal way to the allergen. Hopefully it's just something you can avoid. Any questions on that? Do I have a question? Oh, no. This is something that's real important, but probably only if you're working in the ER. When someone has an allergic reaction, their fingers are going to swell. So always try to get the ring off the finger before it swells. If you break a finger or your fingers begin to swell for whatever reason, most ERs will have a ring cutter, and we've had to use those before. They look like a can opener, but you stick it under the ring and you just screw this thing and it cuts the ring and you take the ring off. And then you put it in a bag and you tell them to take it to their jeweler, and their jeweler can weld it back together again. So no, don't worry, we're not destroying your wedding ring. We just need to get it off because it acts like a tourniquet. And if we don't get that ring off, that finger is going to die. So usually when I tell them that, they're, "Oh, okay, go ahead and cut it off." If the person is scheduled for a skin testing or the RAST testing, be sure they stop any over-the-counter antihistamines, because of course it'll interfere with the test results. I think I told you that in the previous lecture. This is very important. You may be responsible for giving somebody an EpiPen. The doctor will prescribe it, but you need to instruct them on how to use it. And maybe one of our skills labs, we got a couple EpiPens, fake EpiPens. Don't worry, we're not going to poke you. We have a couple fake EpiPens around the unit, and we'll bring it into a skills lab sometime and show you how they work. Client and parent teaching. There again, if you can, just avoid whatever it is that's causing the allergic reaction. Kind of hard to do though when it's like hay fever or something. Anybody have any questions on that? Nope, you guys are just absorbing this like a sponge. Okay, question. A nurse would evaluate the client that he understands what triggers allergic rhinitis by which of the following client responses? What would your client say that would indicate that he understands rhinitis?
D.
D. Ta-da! D, airborne. That's an inhalant. Rhinitis is when your nose starts running. Any question on allergic reactions? Because I think we go into vaccines after this. Yep, we're going to vaccines. Nope. All righty. Bounce on. Vaccines. We're going to go over some of the more common vaccines, what they're for, what type they are. And I'll talk a little bit about the COVID-19 vaccine. I'm going to do an entire lecture on COVID-19. So, because I think it's important. It's important we understand that. So that will be, I think, week 8. I think it's week 8. A vaccine. A vaccine is very simple. What we are doing is we are taking the antigen, the actual culprit, and we're putting it in your body so that your body launches an immune response. So you remember that sensitization period? You catch something, your body reacts to it, builds antibodies, and hopefully kills the disease before the disease kills you. But once you have it and you produce the antibodies and the B cells that produced all those memory cells and everything, the next time you get that antigen in your body will react immediately to stop it from causing its damage. There's several ways we can do that. We can give you the actual virus itself. It's a live vaccine, but the vaccine, it's had its teeth taken out of it, so to speak. It's a very weak dilution. So it's not going to make you sick, but it's enough that it's actually going to cause your body to launch a response, or we can actually weaken the virus itself. This is called an attenuated or weakened virus. A third option is we just kill the virus completely, but we leave all of its markers on its dead cells so that your body can look at those markers and recognize it as an antigen and create an allergic response. Now, COVID-19 vaccine, that's a little different. It's a little different animal. So we'll talk about that next. We had, they found, and I don't know because I haven't had a chance to research it yet, but for some reason, the live, the attenuated, the dead virus vaccines for COVID-19 didn't work. So they had to come up with something new. Those darn SARS. What is the definition of a vaccine? Might want to know that. What type of vaccines are there? Commonly. Might want to know that too. Okay, TD, Tdap, DTaP. We've all seen this. You're all required to have that in order to start this course. The Tdap and Tdap, they're a combination of several vaccines together to cover tetanus, diphtheria, pertussis. Pertussis is whooping cough. If you ever see a young child and he's coughing and it sounds like a dog barking, that's whooping cough. And normally the Tdap will give them to kids under 7. And then when they get up into school age, we'll give them the booster, which is a Tdap. Now the tetanus, the TD, tetanus we used to call lockjaw a long time ago, because I've only seen one case in my lifetime. Tetanus will cause all of your muscles to contract to the point where your jaw locks up, your back locks up, and you're just totally rigid. And the muscles can contract so hard it'll actually break bones. It's a really nasty disease. And that has to be given, every 10 years or so. Lockjaw we call the rusty nail disease because, you step on a rusty nail. It's usually present in the environment. So that's why when you accidentally cut yourself with a rusty knife or whatever, the first thing the ER doctor is going to ask you, when's the last time you had a tetanus shot? Believe me, this is not a disease you want to go through. This is not something you're just going to, I'll just let it pass. So just be sure you stay up on your tetanus shot. The type of vaccine this is called a toxoid, where the disease is a bacteria that causes a toxin, which is what your body reacts to. And so it reacts a little differently than like a virus or the bacteria itself. And they call it a toxoid vaccine. I wouldn't worry too much about that. Moving on. Mumps, measles, rubella, the MMR. First dose usually given around when there's a young baby, 9 to 15. And then again, when they get into school, usually they'll get a second dose when you start going to school between 15 months to 6 years of age. The MMR protects for life. So once you get it, you don't have to get it again. And it is an example of the live virus vaccine. There's also varicella or chicken pox. I remember getting chicken pox. It wasn't fun. Usually it's not fatal, but it can be very damaging to young kids, which is why they came up with the chicken pox vaccine. First dose again as a baby, second dose when you get to school. And it's another example of a live vaccine. Now they used to, when I was really young, measles, they now have a measles vaccine as well. But they used to have measles parties. Some of you may have heard about this. One of the kids in the neighborhood would get measles. All the other mothers in the neighborhood would bring their kids over to that kid's house so that the kid would get measles on purpose so he could develop immunity and they don't have to worry about it again for the rest of their life. So the older you get, the more damaging measles can be. So they used to have measles parties. Thank God we don't have to do it that way anymore. I couldn't imagine having to play with a kid that's got measles. Yuck. The infamous flu shot, something we get every fall. The flu virus is very nasty and it has two different ways of trying to avoid us or avoid us killing it. One of those, it just mutates a lot, which we are very familiar with because COVID's doing the same thing. It just mutates. So last year's vaccines are probably not going to work on this year's flu bug. The second thing that the flu virus does is it covers its antigen with a polysaccharide coating. And this is kind of like hiding under a blanket. It's trying to sneak into your body in such a way that your body will not launch an immune response against it. So these particular flu, what this particular flu shot does is it introduces the antigen to the body while, throwing the blanket off so that the body can actually recognize the antigen for what it is and launch an immune response. That way, if one of those flu viruses does get into the body, that polysaccharide coating won't disguise it. Your body will go, aha, I know who you are, and it'll attack it and create the antibodies. There are two different types. The pneumococcal conjugate is given intramuscularly. That's usually what you get when you go to the hospital and get your flu shot. And the pneumococcal polysaccharide is either IM or subcutaneous. You can really impress the nurse the next time you get your flu shot and go, is that a pneumococcal conjugate or is that a pneumococcal polysaccharide? And she's going to look at you like you're from Mars. I want to remember that. Okay, that's all. Those are the only common vaccines. There are a couple more in your ATI book that you can look at. The ATI book is not really good for explaining what the vaccine is for. It mostly just kind of gives you a schedule. So not a whole lot of information in there, but you can take a look at it. I would not memorize when you're supposed to get the vaccine. That's why they produce vaccine charts. I don't even think school nurses know what the chart's supposed to say from year to year. You just pull out the chart and, if you're a parent, you look at the schedule the doctor gave you and you get your kids in for the vaccine. Hopefully you're getting your kids vaccinated. COVID-19 is a different animal. It uses what's called a messenger RNA or mRNA type vaccine. That is why we couldn't just, when COVID-19 hit, we couldn't just like, boom, whip out the vaccine and away we go, because the standard live attenuated and dead vaccines did not work on COVID-19. Like I said, I would have to do a lot more research to find out why that is, but it is. If you remember back into your anatomy physiology days, you will remember that in the center of your cell is a DNA, which looks like a ladder. If you take that DNA and you rip it apart so that you have half the ladder, that is RNA. And RNA is usually used to send messages from one DNA to another. What they did, and just as a little review on what a virus is nothing more than just a little hunk of RNA with a coating. It gets into your body, that RNA attaches to the cell, and it makes its way into the nucleus of your cell, and it turns your cell into a virus-producing factory. So whatever your cell was doing before the viral infection, it now stops, and it does nothing but produce millions and millions of viruses. And when it's produced a bunch of viruses, it explodes and dies. So that's what the virus is doing in your body, is it's infecting these cells, and it's killing them by turning them into virus infectious factories. And that sounds like a Stephen King novel if you think about it. But the COVID-19 is a typical virus. It's got a little messenger RNA that sneaks into the cell of your body and turns your cells into COVID-19 virus producing factories. This is really clever. What they did was they took a strand of that COVID-19 RNA and they found the little section of it that produces the little spike on the outside of the COVID vaccine, the little marker. Now, you remember back when we talked about the MHC1, the little marker your cells have, that's like their driver's license. Your body sees the MHC1 marker and says, oh, you're okay, you're part of the body. Well, every virus, every cell has little markers on the outside of the shell. Now, they call these, in COVID-19, they call it the spike. Now, if you've seen the picture of the little COVID, the little round COVID virus, and it's got those little red things all around it, those are spikes. They call them spikes, and that's their identifier. That's that cell's MHC1. Well, they took a little piece of the RNA out of the COVID that produces that spike, and they stuck it into a little poly something coating. Can't remember what the name of it is, but they put a little coating on it, and then they inject it into your body. And what happens is that goes to the regular body cell. It injects that little piece of the COVID-19 RNA into your cell. But instead of the whole COVID-19 RNA strand going into the cell and turning it into a virus-producing factory, that little piece of RNA just hangs out in the cytoplasm of your cell, and your cell uses it to manufacture a spike that looks exactly like the spike that exists on the COVID-19 virus. Your cell then produces that spike and puts it on the exterior of that cell, and that bing, 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 lights go off, and your T cells and your B cells and your everything come in, see that spike, and produce a whole bunch of antibodies to fight off that spike. So when a real COVID-19 virus comes by and enters your body, you already have the antibodies to attack it. Really clever. It's really, really clever the way they did that. And it, like, how they did it is totally beyond my level of understanding, but it's really cool the way it works. This technology has been around a long time, but we've not had to use it until now. So this is the first mRNA type of vaccine that I'm aware of that they are actually mass producing. They might have had something for SARS, but I'm not sure. But this is the first time commercially that we've used the mRNA vaccine. Any questions on that? If you haven't watched it yet, I got a little video in this week's module that put out by Pfizer and Moderna, that it has a little cartoon that shows you how that all works. It's really good. It's like 2 minutes long. Is that it? I do, whoop, go back. I do believe that's all. How are we doing for time? Still use a whole hour. God, every time I try to shorten this to 20 minutes, not 20 minutes, but I try to get it down to 30, doesn't work. Any questions on this material before I turn the recording off? No questions? Whoops, where did, oh, that's okay. Okay, if there's no more questions, I'll stop the recording.